Thank you very much, David, for introduction, and it's a pleasure for me to be here. I am going to speak about flow cytometry, chronic myeloid neoplasms, and talk about current recommendations and challenges in this field. I have no financial disclosure. So these are objectives of my talks. I'm going to discuss the role of flow cytometric immunophenotyping in the workup of chronic myeloid neoplasms, talk about current recommendations on application of flow cytometry in diagnosis of myelodysplastic syndrome, and describe strategies and challenges in the flow cytometric evaluation of myelodysplastic syndrome. Chronic myeloid neoplasms are various groups of stem cell disorders that are characterized by either chronic ineffective hematopoiesis leading to peripheral blood cytopenias and symptoms associated with cytopenias, or overproduction and proliferation of myeloid cells leading to peripheral blood cytosis and organomegaly and end organ damage. This table summarizes the new classification of chronic myeloid neoplasm according to 5th edition of WHO, which includes myeloproliferative neoplasms, mastocytosis, myelodysplastic syndromes, and myelodysplastic myeloproliferative neoplasms. In general, as we know, flow cytometry is widely used in evaluation of hematolymphoid neoplasms, particularly lymphoproliferative disorders, plasma cell neoplasms, and acute leukemia. With regards to chronic myeloid neoplasms, the application of flow cytometry is controversial. And that's for different reasons. One reason is that for many of the, especially myeloproliferative neoplasms, the clinical presentation as well as the genetic signature and bone marrow morphologic findings are generally straightforward, and many of these neoplasms do not require flow cytometry for diagnosis. On the other hand, myelodysplastic neoplasms, or MDS-MPN neoplasms, the application of flow cytometry in these disorders is challenging because of the difficulty of panel development, standardization, and the fact that it requires complex interpretation. That's why the application of flow cytometry in these disorders are right now controversial, and many institutions do not perform them. With regards to diagnostic criteria, two categories, mainly systemic mastocytosis and chronic myelomonocytic leukemia. The immunophenotyping of the neoplastic cells has been incorporated into diagnostic criteria. Systemic mastocytosis is the proliferation of mast cells in extracutaneous tissue that commonly involve bone marrows. This is the table that shows the diagnostic criteria for systemic mastocytosis according to 5th edition of WHO. The diagnosis requires either a major criteria and one minor criteria, with the major criteria being presence of a dense aggregate of mast cells, which is more than 15 mast cells in aggregate, or in the absence of a dense aggregate of mast cells, presence of 3 minor criteria. One of these minor criteria is the basically abnormal immunophenotype of mast cells with expression of CD2, CD25, or CD30 by either flow cytometry or immunohistochemistry. There are not many studies that evaluated flow cytometry in diagnosis of systemic mastocytosis. But this study looked at the simple panel to evaluate mast cells aberrancies in systemic mastocytosis, and when the mast cells were gated according to bright expression of CD117, in their standard approach, they looked at the expression of CD2 or CD25 on this mast cell population, and they showed that the sensitivity and specificity of the assay is 77% and 96%, compared to a standard approach, which was bone marrow biopsy. But there was a population, there was a portion of the patients that basically didn't show aberrant expression of CD2 or CD25. Rather, they showed a expanded and discrete population of mast cells, as you can see in the bottom panel. And these were also patients who were actually diagnosed with systemic mastocytosis. So when these patients were included, the sensitivity of the assay increased to 96%, which was exceeding the sensitivity of the bone marrow biopsy. So the message of this paper is that flow cytometry is a good approach for diagnosis of systemic mastocytosis, and this is particularly helpful in the cases that we don't see a discrete mast cell aggregate in bone marrow biopsy. In those cases, often evaluation of aberrancy on mast cells by immunohistochemistry is difficult because these markers CD2, CD25, and CD30 can be expressed on lymphocytes and activated cells on bone marrow. So that's the value of flow cytometry in systemic mastocytosis. Chronic myelomonocytic leukemia is the most common diagnosis in MDS-MPN category. And it's characterized by neoplastic proliferation of monocytes in blood and bone marrow associated with cytopenia in one or more myeloid lineages that could be secondary to dysplasia. This table shows the diagnostic criteria for chronic myelomonocytic leukemia. Most recently, an abnormal partitioning of peripheral blood monocytes was included in diagnostic criteria of chronic myelomonocytic leukemia. So in a normal individual, peripheral blood monocytes can be divided into CD14 positive, CD16 negative population, which is the classical monocytes, intermediate monocytes that express both markers, and non-classical monocytes that express CD16 with dim expression of CD14. In normal individuals, these classical monocytes comprise on average about 85% of the monocyte population. Whereas in chronic myelomonocytic leukemia, this can be actually increased, and it has been shown that more than 94%, presence of more than 94% classical monocytes is highly diagnostic of chronic myelomonocytic leukemia. That's based on this study, which looked at the CMML patients and compared these patients with different populations that such as age match controls, as well as patients with non-CMML hematologic malignancy, as well as patients with reactive monocytosis. And as you can see, in CMML, we have significantly increased frequency of classical monocytes. An ROC curve was used to establish the best threshold for differentiation of these categories, and found a threshold of 94% classical monocytes as the best discriminator between these categories. And when so using the threshold of 94%, the assay has a high sensitivity and a specificity of more than 90%. And this was also confirmed in an independent validation cohort. Importantly, when this threshold was when patients with CMML received hypomethylating agent for treatment, there was the patients who responded to treatment showed significant reduction in the percentage of classical monocytes, indicating that this is a good marker for response to therapy. This same assay was also evaluated by a multi-center European study and found a similar finding with 3 different patterns that they could see in their patient population. Cases that were in favor of CMML, which had more than 94% classical monocytes, patients who were not in favor of CMML, which showed less than 94% classical monocytes, and they also had an interesting subset that showed a pattern that they called it the bulbous aspect, meaning that there was an increase in intermediate monocytes with concurrent decrease in classical and non-classical monocytes. These were actually patients who were diagnosed with CMML, but they had an inflammatory state, which resulted in this pattern of expression. Again, they came up with the same threshold of 94%, which confirms the previous study and establishes a value for this assay in evaluation of chronic myelomonocytic leukemia. This assay is also helpful in bone marrow, and they showed that patients who had concurrent bone marrow and peripheral blood had similar finding in both samples, and the threshold that they established on bone marrow as well was 94%. With regards to Philadelphia chromosome negative myeloproliferative neoplasms, these are again a group of myeloid neoplasms that are associated with proliferation of various myeloid elements, including polycythemia vera, essential thrombocythemia, primary myelofibrosis, and other less common chronic myeloid neoplasms. These, in general, have there are less flow cytometry studies on this group of patients. Some of the reasons, as I mentioned previously, is that generally they have a typical clinical presentation or molecular signature or bone marrow finding that facilitate their diagnosis, and often there is no requirement for flow cytometry beyond the assessment of blast percentage if it is increased. On the other hand, some of these categories actually do not show many findings in flow cytometry, especially polycythemia vera and essential thrombocythemia. And that's why many institutions do not perform flow cytometry when one of these categories are suspected. Nevertheless, there have been some studies that looked at the value of flow cytometry in this setting. One of the first studies was conducted here with Dr. Wood and Dr. Kusik, who looked at the basically non-CML myeloproliferative neoplasms. Actually, this was one of the first studies who established the normal maturation pattern for myeloid elements and monocytic element as well as blast population. And they showed that basically this maturation pattern is very conserved during normal or regenerative marrow, and abnormalities in these patterns can be commonly seen in myeloid neoplasm, including myeloproliferative neoplasms. As an example, this plot shows the normal maturation pattern from the stem cells to mature neutrophils with respect to expression of CD13 versus CD16, which has the classic Nike pattern that is commonly used in flow cytometry lab to evaluate the granulocytic lineage. And abnormality in this pattern is commonly seen in myeloid neoplasms. So it was shown that abnormalities in expression of markers such as increase or decrease expression of some markers, as well as asynchronous expression of markers such as, for example, expression of mature markers on immature cells, or expression of immature markers on mature cells, can be seen in setting of myeloproliferative neoplasms. So among 66 patients that they had in this study, 30 of them had abnormalities by flow cytometry. Many of them showed abnormalities in blast population, as well as granulocytes, and to a lesser extent, abnormalities in monocytes. So it appears that flow cytometry can be helpful in the setting of the chronic myeloproliferative neoplasms. Another study from MD Anderson looked at different looked at the myeloproliferative neoplasms and looked at the patients with essential thrombocythemia, polycythemia vera, and primary myelofibrosis. And they found that a significant number of these patients also have abnormalities on either blast population or maturing myelomonocytic cells. But the caveat with this study was that a significant number of these patients had later stage disease with overt fibrosis and increased blast, which makes their cohort actually maybe not representative of the whole MPN population. Nevertheless, they found less abnormalities in MPN compared to similar age-matched MDS cohort. So as expected, the flow cytometry abnormalities are less common in MPN as compared to MDS. But these abnormalities could be in MPN patients. The abnormalities are more commonly seen when there is overt fibrosis, or when there is increased blast population or abnormal karyotypic findings. So to summarize, in the setting of Philadelphia chromosome negative myeloproliferative neoplasms, flow cytometry findings are less common compared to MDS, but they may be helpful when a progressive disease is suspected. Myelodysplastic neoplasms are a group of stem cell disorders that are characterized by ineffective hematopoiesis leading to peripheral blood cytopenias, morphologic dysplasia, and propensity to progress to acute myeloid leukemia. Diagnosis of MDS requires the presence of morphologic dysplasia in at least 10% of either erythroid, myeloid, or megakaryocytic lineages. The presence of dysplasia in association with blast percentage, presence or absence of ring sideroblasts, or characteristic cytogenetic or molecular abnormalities are used in diagnosis and subclassification of myelodysplastic neoplasms. However, there are some limitations in the MDS diagnosis. Maybe the main limitation is that there is significant inter-observer variability and subjectivity in interpretation of dysplasia. In addition to that, there are many non-neoplastic causes of cytopenia or dysplasia, such as nutritional deficiencies, viral infections, autoimmune conditions, and which may complicate the diagnosis, and these conditions need to be excluded before a diagnosis can be established. Cytogenetics abnormalities can be seen in about 50% of MDS cases, but again, these are less common in low-grade MDS, where the most diagnostic challenge is present. NGS finding and somatic mutations can be found in about 80 to 90% of MDS cases, but again, there is significant overlap between a pre-malignant condition of clonal cytopenia of undetermined significance, and in fact, in the latest WHO, other than SF3B1 and TP53 mutations, no other mutations is considered diagnostic of MDS. Given that the MDS diagnosis has a lot of challenges, there is a need for objective measures in cases which have borderline morphologic findings. There is, as I mentioned, there is significant objectivity and inter-observer variance in diagnosis of myelodysplastic syndrome. This study showed that in the setting of low-grade MDS, approximately 1/3 of cases, there is a discordance diagnosis between two trained hematopathologists. When the diagnosis is MDS with single lineage dysplasia, this discordance is actually more than 2/3 of cases. So again, that shows that evaluation of morphologic dysplasia is often very challenging and subjective. There has been many studies looking at the value of flow cytometry as an objective measure to evaluate dysplasia when a diagnosis of MDS is suspected. Since early 2000s, there have been several studies looking at abnormalities that can be seen in the setting of MDS, and it has been shown that numerical or immunophenotypic abnormalities in blast population or maturing myeloid or monocytic lineages can be seen in the setting of MDS. For example, in this paper, they show a number of examples where you can see abnormalities in granulocytes or monocytes, such as expression of HLA-DR on granulocytes, which is abnormal, or loss of HLA-DR in monocytes, which is abnormal, or abnormality in the expression of lymphoid markers on granulocytes or monocytes. But as we know, MDS is a genetically complex disease, and as a result, there is a highly variable expression of immunophenotypic abnormalities. Therefore, there is no single marker that has sufficient sensitivity and specificity for MDS diagnosis, and therefore different parameters were combined to generate a scoring system which is more robust in diagnosis of MDS. One of these scoring systems was established by Dr. Wells and a colleague, which looked at different abnormalities in myeloid elements as well as monocytic and blast populations, and different scores were given depending on the type of abnormalities, with a total score of 0 to 1 considered mild or normal, a score of 2 to 3 was considered moderate, and a score of 4 to 9 was considered severe dysplasia. They showed that their scoring system has a sensitivity of about 70% and a specificity of about 93% in diagnosis of MDS, and in fact in post-transplant setting, they showed that this scoring system is predictive of relapse and survival of the patients. A relatively simpler but more practical approach was Ogata score, which looked at the 4 of the parameters that can be commonly abnormal in setting of MDS, namely myeloblast percentage, percentage of B-cell progenitors, as well as CD45 expression on myeloblast, and side scatter of the granulocyte, which each parameter was given a score of 1, and a score of 2 or more was considered diagnostic for MDS. And again, they showed a similar sensitivity and a specificity, with sensitivity of about 70% and a specificity of more than 90%. And also they showed that the higher score is associated with lower survival and higher risk of leukemic transformation. There are also groups that looked at aberrancies in erythroid cells, and they showed that abnormalities in erythroids, such as decreased expression of CD71 or CD36, or increased coefficient of variation of these markers is associated with MDS. There has been a lot of studies done by the International and European Leukemia Net working group for MDS flow cytometry, and they published several recommendations. One of these publications in 2014 give these recommendations for MDS flow cytometry in MDS. First, they indicate the usefulness of Ogata score in the setting with limited resources and smaller laboratories, but they acknowledge that this scoring system has lower sensitivity. They advise for use of a more comprehensive panel for more detailed immunophenotypic analysis of different hematopoietic cells. And they indicate that presence of at least 3 aberrant features in at least 2 cell compartments are highly associated with MDS and MDS-MPN. They emphasize on the importance of integrated reporting, meaning that flow cytometry should be incorporated into diagnostic report together with morphologic, cytogenetic, and molecular finding. And if flow cytometry is reported independently, it should be descriptive, and conclusion about MDS diagnosis should be avoided. This table shows different markers or combination of markers that can be used in evaluation of the aberrancies on progenitor myeloid cells, neutrophils, monocytes, progenitor B cells, and erythroid cells. As you can see, this is a very extensive list of markers, which include, for example, parameters that are present in Ogata score, some abnormalities in maturation patterns, as well as aberrant expression of lymphoid markers on various cell population and abnormalities in erythroid elements. But as you can see, this is this application of this panel requires multiple tubes with several antibodies, which is costly. In addition, interpretation of these results would be requires a lot of time from the pathologist side. So some of the challenges in flow cytometry of MDS, to summarize, is the first lack of a specific marker for diagnosis, which requires combination of markers to generate a scoring system. But the scoring systems, if they have limited number of markers, have lower sensitivity, whereas if we use a more comprehensive panel, it is associated with higher cost and need for expertise in interpretation. In addition, there is a lack of clarity about the thresholds and cutoff values for many of these parameters, which makes the interpretation often subjective. Another caveat is that some of the aberrancies on myelomonocytic cells, such as expression of markers or granularities, can be affected by a storage time fixation, hemodilution, or marrow regeneration, which makes those aberrancies less specific. So the question is, why not focusing on blast population in MDS? So blasts are actually ideal target for evaluation in the setting of MDS, because MDS and MDS-MPN are clonal stem cell disorders, and blasts are expected to be affected in almost all cases. In addition, both frequency and immunophenotypic aberrancies of the blast population can be evaluated. And flow cytometry can identify blast abnormalities in the absence of a good definition for the dysplastic blast population. We know that blast immunophenotype is more stable than maturing myelomonocytic cells, and they have higher specificity. Some of the blast abnormalities that can be seen in MDS or MDS-MPN include some features that are better studies, such as increased frequency of myeloblast or decreased frequency of hematogones, abnormal intensity of markers that are normally expressed on myeloblast, asynchronous expression of markers associated with maturity, such as CD11b and CD15, or expression of lineage infidelity markers, such as expression of B, T, or NK cell markers on the blast population. But there are some abnormalities in the blast population that are less well studied, such as abnormal blast heterogeneity or changes in the frequency of stem cells and stem cell aberrancies. In general, the CD34 positive blast population is a heterogeneous population, and that is because the CD34 positive population undergo a series of maturation stages, starting from hematopoietic stem cells, which lack CD38, and differentiate into different progenitor cells that produce different lymphoid progenitor and myeloid progenitor, such as granulocyte monocyte progenitor and megakaryocyte erythroid progenitor. So if this heterogeneity can be reduced or lost in the setting of myeloid neoplasms. For example, this group has shown that high-grade MDS is associated with increased frequency of stem cells. In addition, if we look at the different progenitors in the myeloblast population, a normal myeloblast population had a heterogeneity with respect to different myeloid progenitors, whereas in a high-grade MDS, we can see increased frequency of granulocyte monocyte population and decreased frequency of megakaryocyte erythroid progenitors. Whereas in low-grade MDS, we can see increased frequency of common myeloid progenitor. So we decided to study different immunophenotypic abnormalities in the blast population using a panel that can evaluate various aspects of CD34 positive blasts. So we use this panel, which is a 1-tube 10-color 13-marker panel that has markers for gating on blast and stem cell populations, markers to evaluate myeloblasts, such as CD33, CD117, markers that can differentiate different progenitor populations, and markers that are known to be aberrantly expressed on the myeloblast population, and some markers that are known to be expressed aberrantly on the stem cell population. So stem cell in the setting of AML or MDS are some of the markers that they can express is bright expression of CD123 or CD33 or aberrant expression of lymphoid markers. Two other markers that are commonly seen in the setting of stem cell aberrancy in MDS or AML is CD45RA and CD371. CD371, which is also known as CLL1, is a myeloid marker which is expressed on granulocyte monocyte progenitor stage and is present throughout the maturation of myelomonocytic cells. It is not normally expressed on hematopoietic stem cells, but its expression is abnormal in the setting of MDS or AML. So this was the gating strategy that we used in this study. We looked at the regular DIM45 population and gated on the myeloblast population, which expresses CD34 and CD117, and hematogon population, which does not express CD117, and also the stem cell population could be gated based on the lack of CD38 expression. This is a normal bone marrow, and we can see different populations that were evaluated in this study, and also parameters that we looked at. So we looked at the percentage of myeloblast population as well as the percentage of hematogon population, expression level of CD45 on myeloblast, as well as expression of other markers such as CD117, CD123, CD38. So we basically always assess the mean or median fluorescent intensity of these markers. And in fact, we established reference ranges for our normal bone marrow to be able to evaluate abnormalities in the level of expression of these markers. We used this panel, this plot of CD45RA versus CD371 to evaluate myeloblast heterogeneity. Normal myeloblast showed population in all 4 quadrants, but as you can see, this heterogeneity is lost in many of our cases. So this was very good for assessment of heterogeneity. With regards to a stem cell population, we looked at aberrant expression of different markers using these gates, as you can see here. Just to a little bit elaborate on the heterogeneity of the myeloblast population, as we know, this is a population that differentiates into different cell lineages. If we look at CD123 versus CD45RA plot, the myeloblast population can be divided into common myeloid progenitors, as well as granulocyte monocyte progenitor and megakaryocyte erythroid progenitor. Granulocyte monocyte progenitors have the highest expression of the myeloid markers CD33 and CD371, whereas megakaryocyte erythroid progenitor has the lowest expression of these markers. And that's the reason we see this heterogeneity in the myeloblast population with respect to expression of these markers. As you can imagine in myeloid neoplasms, there is preferential expansion of one of these populations, leading to reduction of heterogeneity in the myeloblast. So these are the characteristics of the study patients, which, to briefly mention, we had 23 MDS cases. We had 8 MDS-MPN cases and 21 cases of cytopenic patients that did not meet the criteria for MDS, and we call them non-MDS cases. And this is the diagnosis for the MDS and MDS-MPN category. The MDS-MPN category comprised mostly of CMML patients. This is an example of aberrancies that we could see with our panel. This was a case of MDS with multilineage dysplasia that showed slightly increased myeloblast population, about 2.2%, that showed increased intensity of CD117 expression, increased intensity of CD123, and abnormal myeloblast heterogeneity with increased percentage of CD45RA and CD371. In addition, there was an abnormal stem cell population that was shown by expression of CD371. So these plots show different abnormalities that could be seen in MDS and MDS-MPN cohort compared to non-MDS or our controlled bone marrow samples. MDS was associated with increased percentage of myeloblasts. Both MDS and MPN cases showed reduced percentage of stage 1 hematogones. And there were a significant number of cases in MDS and MPN, MPN group that showed abnormalities in CD45 expression. CD117 was significantly increased in both MDS and MPN cases, and CD38 was decreased in both groups. And CD123 was increased in the MDS-MPN category. A significant number of MDS and MDS-MPN cases had abnormalities in the expression of CD45RA and CD371, meaning that they had abnormal heterogeneity. And stem cell aberrancies were seen again in a significant number of MDS cases. So this figure shows all the abnormalities that could be seen in this study cohort of MDS and MDS-MPN patients, and these are parameters that we evaluated in this study. Overall, we had 10 blast parameters and 2 myelomonocytic parameters, and we generated a scoring system which we gave a score of 1 to each abnormal finding in any of these parameters, with the exception of myeloblast percentage, which we gave a score of 2, and a score of 3 or more was considered immunophenotypic evidence of myelodysplasia. Using this scoring system, as you can see, we could identify all cases of MDS-MPN and a significant number of MDS cases, with only 2 false positive cases in non-MDS cases, overall giving a sensitivity of 87% for the entire cohort of MDS and MDS-MPN, and a specificity of 91%. The sensitivity for lower risk MDS was 75%. So overall, what it showed that we could generate a scoring system that was totally quantitative and did not require the evaluation of complex maturation patterns, and is very helpful in diagnosis of MDS, especially because this can be totally automated and remove the need for interpretation by pathologists. We further expanded on this study and included a validation cohort of similar size MDS and MDS-MPN and non-MDS cases. And these plots also show abnormalities, which we saw on the second cohort, which we call it validation cohort here, as compared to the first cohort, which we call learning cohort. Again, these are the parameters that we looked at on the blast population, with some slight modifications, which I will not go through them. But one thing that we added in this study was the side scatter of the blast population, which was abnormal in a significant number of MDS and MDS-MPN cases. Just to give some examples of the cases that we had, which showed effectiveness of this approach, even at low blast percentage of, for example, 0.39%. You can see this case was a case of MDS with single lineage dysplasia that showed a slightly decreased expression of CD45 with a slightly increased expression of CD117, increased expression of CD123, and abnormal heterogeneity of the myeloblast population with increased expression of CD45RA and CD371, giving a flow cytometry score of 5, which was positive for immunophenotypic evidence of dysplasia. This was a case of CMML0, which had a blast percentage of 0.48%, but had significant increase in the expression level of CD117 with loss of hematogene population, increase in the expression of CD123. The heterogeneity of the myeloblast was relatively conserved, but there was a slight decrease in the side scatter of the granulocyte population. Overall, the score was 4, which was diagnostic for MDS. This was a case of MDS-MPN unclassifiable which showed a slightly increased myeloblast percentage of 3.2%, but showed abnormalities in myeloblasts, including increased side scatter of myeloblast population, decreased expression of CD45, increased expression of CD117, decreased expression of CD38, and abnormal heterogeneity of myeloblast population. In addition, there was abnormal stem cell population with expression of CD45RA and CD371, giving a flow cytometry score of 8. This was a 36-year-old man who presented with macrocytic anemia, and on morphologic evaluation of bone marrow, there was significant megaloblastic changes in the erythroid population, as well as dysplastic feature in a subset of erythroid elements. As you can see, there was a significant expansion of the erythroid population here, but the blast population looked relatively normal with no increase in the percentage. The hematocone population was preserved, and the expression level of CD117, CD38, and CD123 was normal with the preservation of normal heterogeneity. Overall, the score was only 1, and this patient turned out to be a patient with B12 deficiency. Overall, it appears that the assay performed well in the setting of non-clonal cytopenia and dysplasia. So this figure again summarizes all the abnormalities that we saw in non-MDS, MDS, and MDS-MPN cases with different parameters that we evaluated. We had 11 blast parameters and 2 myelomonocytic parameters. And again, we used the same scoring system and showed that this scoring system is very effective in diagnosis of MDS and MDS-MPN. In fact, the sensitivity of the assay in MDS-MPN and high-grade MDS was 100%. Overall, the sensitivity was 90%, with low-risk MDS sensitivity of 81%. With a specificity of 94%. As compared to Ogata parameters, you can see that when we use Ogata parameters, the sensitivity and specificity is much lower compared to the study parameters. And one more comment that I have here was that the scoring system appeared to have a correlation with IPSS prognostic risk group, as the IPSS score was increasing. There was an increase in the blast in the flow cytometry score, meaning that higher scores are likely associated with worse prognosis. So to summarize, we found that flow cytometry is valuable in diagnosis and prognostication of MDS and MDS-MPN, and deep immunophenotypic analysis of the blast population can provide high sensitivity and specificity values that are comparable to those of more comprehensive panel. And we showed that there is a value in evaluating myeloblast heterogeneity and stem cell aberrancy. And in fact, quantification is very helpful in this regard. Finally, I just want to thank my colleagues from my previous institution who helped me with this study, as well as thanks to the great work that was done by the flow cytometry lab. I'm happy to take any questions. Thank you.
I had a question about the prognostic value of the flow cytometry immunophenotype that you presented. You mentioned in the very last slide the sort of correlation between risk group and flow score. But in the very low risk and low risk categories, there are some people with fairly elevated scores. I'm wondering if you have information on the clinical trajectory of those patients, and if you're potentially picking up folks who by cytogenetics, for example, have low risk, but actually there's a subpopulation of patients who are in fact not low risk, even though traditional scoring systems would place them in that category?
Yeah, that's a very good question. So no, unfortunately, we do not have the data on the survival or leukemic transformation of those patients. In fact, we didn't follow up the patient, our patient population, and that's why we don't have survival curve on this patient population. But that's a good point, because we haven't studied that, but other groups have shown that if you look at the low IPSS-R risk group, the patients who have higher flow cytometry scores are generally doing worse than the patients who have lower flow cytometry scores. Thank you.